Welcome to this explainer. Okay, imagine the human body is a massive, complex building. The pituitary gland, well, that's the master switchboard, down in the basement, routing literally every vital signal that keeps a whole system running. But what happens when that switchboard takes a massive hit? Today, we're breaking down the dramatic physiological fallout of acquired hypopituitarism. So what actually happens when the body's master control center just goes offline? Now, to be clear, we aren't talking about being born with a faulty system. We're skipping past congenital issues today. Instead, we're looking strictly at acquired damage. This is all about a totally healthy, perfectly functioning switchboard that suddenly gets crushed, starved of blood, or infiltrated by disease. Okay, let's dive into this. Here's our roadmap. First, we'll look at the causes of pituitary failure, then the cortisol crash, followed by pituitary emergencies and mimics. After that, we'll tackle the empty cella mystery, and finally, testing and treatment rules. All right, Section 1, Causes of Pituitary Failure, or exactly how the gland gets damaged. Usually pituitary breakdown starts mechanically, right? Just pure physical pressure. So the very first thing that should pop into your mind for clinics and exams is the stalk effect. Think of the pituitary stalk like a vital data cable connecting the brain to our switchboard. When a tumor compresses the stalk, it literally pinches that cable. And here is the fascinating paradox. It starves the gland of releasing hormones, meaning most pituitary hormones absolutely plummet. But it actually raises prolactin. Wait, why? Well, because the hypothalamus normally sends dopamine down the stalk specifically to suppress prolactin. So you pinch the cable, you cut off the dopamine, and boom, prolactin levels rise while the whole rest of the system fails. But stalk compression isn't the only culprit. Tumors like prolactinomas and craniopharyngiomas are right at the top of the list, for sure. But it gets absolutely fascinating from there. The causes range from high-dose radiation of over 18 gray to infectious diseases like tuberculosis and histoplasmosis. You even have infiltrative causes, like pediatric Langerhans cell histiocytosis, which, by the way, you'll spot by lytic bone lesions, Burbeck granules, and CD1A markers. And get this, depending on where you live, something as wild as viper bite necrosis is actually a leading, surprisingly common cause of pituitary failure. Crazy, right? Moving on to Section 2, the cortisol crash. This is the most dangerous hormone loss. So the crucial point here is that when an adult's pituitary fails, the clinical presentation heavily clusters around the loss of ACTH, the messenger that tells the body to produce cortisol. As adults, we are constantly facing physiologic stress, and it's this sudden loss of cortisol signaling that literally brings the human body to its knees. Let's walk through this high-yield crash profile. The corticotrophs that produce ACTH are centrally located in the gland, which makes them incredibly vulnerable to compression. When they fail, you're going to see extreme fatigue, asthenia, and severe weight and appetite loss. It can honestly mimic a malignancy. You'll also see hypotension, or at least postural hypotension, and tachycardia. And definitely notice the eosinophilia. Cortisol normally suppresses eosinophils, so when cortisol drops, those eosinophil counts just spike. But the massive red flag here, repeated unexplained hypoglycemia in a patient who does absolutely not have diabetes. If you see that, you need to think ACTH crash immediately. Now, you might be wondering, how do we distinguish this pituitary failure from a direct problem with the adrenal glands themselves? Well, in primary adrenal insufficiency, the adrenal gland itself is broken. The body is practically screaming for cortisol, pushing ACTH sky high, which actually causes hyperpigmentation. But the gland just can't respond. This leads to a loss of both cortisol and aldosterone, causing severe salt cravings and hyperkalemia. However, in secondary adrenal insufficiency, which is exactly what we see in pituitary failure, ACTH is low. But here's the kicker. The renin-angiotensin-aldosterone system still completely controls aldosterone. So what does that mean for the patient? It means no massive salt wasting, totally normal potassium, and absolutely no hyperpigmentation. All right, on to Section 3, Pituitary Emergencies and Mimics, or what happens when the switchboard bleeds. So what actually happens when the switchboard starts bleeding? Well, this takes us straight into a high-stakes emergency room scenario. And I really need to emphasize this strongly. Pituitary apoplexy is the absolutely only true emergency we cover in this explainer, period. It's defined as an acute hemorrhage, bleeding directly into the pituitary gland. Usually this happens inside an existing adenoma, or sometimes just spontaneously in patients with diabetes or hypertension. It essentially obliterates the gland instantly, creating a massive, completely life-threatening endocrine crash. Let me guide you through this hyperacute sequence on the timeline. Day 0, bleeding occurs into the adenoma. Over the next 1 to 2 days, the patient develops a relentlessly increasing, incredibly severe headache, potentially even with meningeal signs. But pay close attention to the casualty presentation here. It's not just the headache driving the emergency, it's the physiologic crash. The sudden drop in all those pituitary hormones causes extreme hypoglycemia and hypotension. The immediate intervention, you absolutely must give 100 milligrams of hydrocortisone right away and get neurosurgery on the phone for decompression. And this brilliantly illustrates the difference between two really complex postpartum mimics. On one hand, you have Sheehan syndrome. This is pituitary necrosis, literally tissue death due to severe blood loss and shock during childbirth. Because it physically destroys the gland, it presents with delayed lactation failure, hypogonadism, and crucially, low prolactin. Lymphocytic hypophysitis, on the other hand, is completely different. It's an IgG4-related autoimmune inflammatory mass. It presents with headaches, it usually causes high prolactin due to that stock effect we talked about earlier, and unlike Sheehan, it is brilliantly responsive to steroids. Honestly, surgery is rarely needed if you spot this one.
Okay, Section 4, the empty cella mystery. Is it an illusion or a failure?
Let's dive right into a radiologic mystery that tricks students and doctors alike. A primary empty cella happens when cerebrospinal fluid leaks through a dural tear and fills up the cellar space. On an MRI, sure, it looks empty, but the pituitary gland is actually just squished into a thin, perfectly intact rim. It's literally a radiologic illusion. There is absolutely zero hypopituitarism here. Conversely, a secondary empty cella means the gland has truly shrunk and been destroyed by a tumor or necrosis, kind of like after Sheehan syndrome. In this case, there is a true endocrine failure. So remember, primary means the hormones are totally fine, secondary means the master switchboard is genuinely broken.
Finally, Section 5, testing and treatment rules. How we rescue the master gland.
Diagnostics and strict pharmacology are really the name of the game here. As a clinician, you'll eventually be faced with this exact question. How do you test an invisible hormone deficit? Things like growth hormone and ACTH fluctuate so rapidly that just directly measuring a baseline blood level is often totally inadequate. So how do we actually prove the pituitary can still send signals to the rest of the body? Well, the answer is dynamic testing. We use provocative tests to essentially force the pituitary to prove it can still work. Take the insulin tolerance test. It uses 0.1 units per kilogram of insulin to drop blood sugar and provoke a cortisol response at around 30 to 45 minutes. Then you've got the casentropin or synacthin test, which uses 250 micrograms of synthetic ACTH to see if the adrenal glands are even awake. The glucagon stimulation test helps us assess growth hormone, and then there's the medirapone test. This drug blocks the very final step of cortisol production. Now, in a healthy person, the pituitary senses this sudden cortisol drop and practically panics, pumping out massive amounts of ACTH to compensate. But if the pituitary is damaged, that rescue surge simply fails to happen. Okay, so once we actually confirm the diagnosis, we have to follow these absolute golden rules of replacement. Step 1, replace glucocorticoids, specifically cortisol. Step 2, replace L-thyroxine. And listen, the order here is totally non-negotiable. You absolutely must confirm adequate cortisol before ever giving thyroid hormone. Why? Because giving L-thyroxine first speeds up cortisol catabolism. It will literally clear out whatever tiny amount of cortisol the patient has left, throwing them straight into a severe hypocortisolemic state. So always rescue the cortisol first. Let's move on and see how this builds into our daily pharmacology. It really requires precise conversions. For instance, 0.75 milligrams of dexamethasone is equivalent to 4 milligrams of methylprednisolone, 5 milligrams of prednisolone, 20 milligrams of hydrocortisone, and 25 milligrams of cortisone. Knowing these exact equivalents allows you to adjust doses precisely. This is absolutely crucial, especially when a patient is facing an infection and needs stress dosing to double or even triple their intake. Now, for standard daily replacement, hydrocortisone is definitely preferred because it has the least negative effect on bone mass compared to the others. The strict routine regimen we use is called the 10-5-5 rule. That means giving 10 milligrams in the morning around 7:30 or 8 a.m., 5 milligrams in the early afternoon around 1:30 or 2 p.m., and then another 5 milligrams in the late afternoon, say 4:30 or 5 p.m. It's pretty brilliant because this elegantly mimics the body's natural circadian rhythm, giving the patient a surge of energy to wake up and then tapering off naturally so they can actually sleep at night. So we've covered the mechanical failures, the systemic crashes, and that strict hierarchy of life-saving treatments. But, it really all comes down to recognizing the patterns before it's too late. So I want to leave you with this provocative final thought. If the master switchboard fails, will you spot the critical warning signs, like an adult with repeated, totally unexplained hypoglycemia, before the system completely crashes? Think about it. Study these diagnostic patterns and be ready to act. Thanks so much for joining me on this explainer, and I'll see you next time.